Let me read her CV for you all. Dr. Nur Kasihan graduated from University Kebangsaan Malaysia, UKM, and she obtained her PhD in renal pharmacy and medication safety at University College London, UCL, United Kingdom in 2014. Dr. Kasihan has practiced as a hospital pharmacist in the Ministry of Health over 18 years, particularly in renal pharmacy practice. She was actively involved in the development of nephrology MTAC and clinical service. Dr. Nur Kasihan Ibrahim has recently joined the ITN as a principal lecturer in the Department of Pharmacy Practice. Over to you, Dr. Nur Kasihan.
Question again. Can I confirm that my voice is heard? Yes, and my PowerPoint? See? Okay?
Good.
All right then. Okay, Assalamualaikum and good afternoon to our Dean, Dr. Shariza, the Secretariat and speakers as well as all participants. I'm Nur Kasihan. I will be speaking about the experience and sustainability in nephrology medication therapy. Right. The content of this presentation does not include the changes in the planning and policies affected by COVID-19 pandemic, and the narratives are influenced by my personal experience following positions as stated in this slide. I have divided my presentation into 3 parts. For us to appreciate the experience, challenges, and the sustainability plan, we must also understand the disease burden in the country. Yeah. Now, to start off with the first part, basically around 2 to 3 million of Malaysian population are living with chronic kidney disease. However, only 4% are aware of their diagnosis. This leads to approximately 8,000 new individuals that requires hemodialysis every year, and the estimated cost of dialysis per patient a year is around 40,000. And what we see now is the scenario of kidney disease in Malaysia. The ones that are referred for special care at this part are already in the late stage. So the numbers that we see in the local registry are derived from this subpopulation, whereby 10% of this population has the opportunity or fit to go for transplantation. The vast majority of other people who are having chronic kidney disease are not known, basically. So the numbers that are tabulated here are an estimation from a sub-study of the National Health Malaysian data in adult people at the West Malaysia. And our country is the top 10 when it comes to the highest percentage of end-stage renal failure incidents due to diabetes. Our patients are also getting younger, yeah. And when it comes to the drug expenditure, this pie chart is showing the distribution of expenditure from nephrology medication. 50% of the annual drug budget is used on transplantation, which will benefit less than 10% of the population cohort. And when we talk about transplantation, one of our concern is the magnitude of non-adherence, where non-adherence to immunosuppressants is quite a concern, because knowing that it is a key for successful transplantation, we are still struggling to improve the rates of adherence. And non-adherence in post-kidney transplant are much more higher as compared to transplantation of other solid organs. Right. So this busy slide that you are seeing now is showing two care models. The one that is on my right side, I would say, this is the ideal care model for nephrology patients, where all comorbids are centralized. The information are centralized and made known to one specialty. But this model, even though it is doable, it requires a large change in the current healthcare model. So therefore, in majority countries, including Malaysia, we are still at this diagram here on the left-hand side. So this is the generic free-for-all care model for nephrology patients, which requires them to be seen by many clinicians for various comorbidities. So this fragmented system is not helping in addressing non-adherence. And when that happens, it contributes to treatment failure as well as unnecessary increase in cost. Right. So now, when we understand a little bit about the demography of our patients and the burden that it is costing for the country, now we will try to look into the experience in Malaysia, how pharmacists look into the opportunities back then, and what can we do to look into the opportunities the way forward, and how we can fill in the gap. Right. This busy slide that you're looking now is showing the clinical pharmacy development in Malaysia for the last 20 years. Nephrology MTAC, the topic that we are interested in this presentation at the moment, is a product of a rapid development in clinical pharmacy practice in Malaysia. So even though the practice has started earlier in the 1980s, however, the progressive development in human capital, financial resources, and training were apparent starting the year of 2000. And the peak of the progress development is between 2006 to 2010, when the clinical service were incorporated into the National Pharmaceutical Service. As I had the opportunity not only to witness, but also experience the changes during this, I would say, the golden era, I think I'm very confident and proud to say that the senior pharmacists during those times were very confident and had a very clear vision on how the agenda of clinical pharmacy services should be brought forward for the nation within 5 to 10 years back then. So what I want you to summarize from this slide is that the first significant move was in year 2000 with the establishment of the Clinical Pharmacy Committee at the ministry level to plan and implement development initiatives. So the first 5 years after their inception were invested in building human capital, adaptation of international initiatives, and standardization of operating procedures in the country. So that was the reason, one of the main factors how Renault, Transplant, MTAC was born in year 2004. The next 5 years was invested in implementation of policies and quality assurance measures, building champions from the grassroots and leveraging in clinical expertise. So this produced the clinical specialties that we see today. To say as an example, renal nephrology pharmacy, respiratory pharmacy, cardio pharmacy, and diabetes pharmacy. All those subspecialties were pioneered by the batch that has received overseas training in the second overseas training here in the USA. And what we see now, the subsequent years, is the maintenance and acknowledgement, gaining acknowledgement from the national level. And in 2018, fortunately, we finally received the acknowledgement on expertise on the approval of the subject matter expert position for pharmacists in the Ministry of Health. And we look forward on the advancement of this post in the near future. Right. So nephrology pharmacy piggyback on this. Yeah. So this slide, outlines the prominent milestones in developing nephrology pharmacy practice over the last 20 years. What I would like to highlight here was number one, the 2 out of the 3 international trainings that was done during the inception of the Clinical Pharmacy Committee was represented by pharmacists who are in the nephrology service. Yeah, so the first one was at USA, and that comes out with the Renault Transplant MTAC, and we managed to start with the national training for MOH pharmacists. And the second training attachment in Australia looked into skills of pharmacotherapy management for kidney disease, and especially in transplantation. The second thing that I would like to highlight in this slide is the training attachment. We started training pharmacists who were working in the Malaysian MOH hospitals, started from 2005. And when the need for having a private transplant center emerges in our country, the similar training is now also offered for private hospital pharmacists. And this happened in our first intake of private hospital pharmacists for Renault pharmacy training was in 2014. And the third thing that I would like to highlight here is the 5-year plan blueprint on how nephrology pharmacy should be brought forward for the betterment of our people. And this includes the MTAC program, and that will be discussed further in the third section of my presentation. So having all these activities, we also want to bring pharmacists outside of the hospital wall. Yeah, we want to get engaged with the people. We want the people to know that actually pharmacists exist to help make their life better, especially in medication management. And we also looked into collaborating with other healthcare providers at the national and international level. Right, so what happens after this? When things are doing well, we find that there is a poor transitional care from what happened inside the wards and hospital to outside once the patient is being discharged. Yeah, and this gap, other than the poor transitional care, it was also contributed to our public and patients' health literacy and beliefs, the fragmented management that we saw just now, and also some socio-economic challenges. In terms of the socio-economic challenges, there are also concern of inaccessibility to treatment and medications, and patients seem to be missing their appointments. Okay, so that was one of the reasons why the National Clinical Pharmacy Committee looked into expanding the role of pharmacists in transition care. Even though the buds of this was started early and that produced the MTAC program, the Renault Transplant MTAC program, however, the effort has never stopped and it keeps on improving and progressing until today. So that's why the Medication Therapy Adherence Clinic was introduced in Malaysia to improve on the quality, safety, and cost effectiveness of patient care at the ambulatory setting. Specifically on nephrology MTAC, there are 3 types of MTAC in nephrology field, which is the CKD, chronic kidney disease MTAC, dialysis MTAC, this program operated by Renault pharmacists in collaboration with the Renault nurses and nephrologists, where we do activities such as reviewing medication, identify medication problems, its management, and also empower patients to take charge of their treatment. And I would like to bring you back to the year that Renault Transplant MTAC was being initiated, yeah, because this is part of the experience. It is not only Renault Transplant MTAC who was at the beginning line. There were several other MTACs who started at the beginning line. However, after the proposal and efforts of collaboration meetings, it seems like Renault Transplant MTAC has the upper arm to proceed forward as compared to other MTAC at that particular time, and this is due to the strength that we had. There was a very strong support from stakeholders, not only from the pharmacy fraternity, but also our collaborators, the hospital director, the clinical team, and the patient. One of the main reasons is because during the early 2000s and late 1990s, kidney transplantation was at the height of our national service in Malaysia. And we don't have many patients. Patients opt for overseas transplantation, which is cheaper. And when they come, the management is a bit not optimized. So having another counterpart, let's say the pharmacist offering some clinical expert skills to manage the patient was very much welcome. So that was the reason why we had the upper arm to move forward as compared to other MTACs. Yeah. And to ensure that the program is being conducted at a standard manner, almost all MTAC has a standard protocol. As you see what Mr. Jeevan has presented just now, and also diabetes or respiratory that you're going to have the opportunity to listen to later on. We have a standard protocol to ensure a minimal variation in the quality among centers providing the service. And from the first year that MTAC was introduced until now, we have a total of 19 MTACs, renal transplant, and then followed by dialysis and chronic kidney disease 4 and 5 years respectively. And all these MTACs are offered at most Ministry of Health hospital, and the process that they have to go through in its establishment are the same, by a SWOT analysis, standardization of protocol, rigorous training, and also collaboration with other healthcare providers. Right. I would like to show here the distribution of nephrology MTAC by number of clinics. It is not the number, the value of the number that I would like to show. What I want to emphasize more is the ups and downs here. Yes, the first few years, you're going to see very rapid increment from 15 to almost triple. Yeah, but then as we go along, there are times where we have to close down and restart or reclose certain centers across the country. So what we are now starting to see the challenges to sustain the service, and factors that contribute to the ability or the inability of a center to sustain the service can be subdivided into 3 main themes. Yeah, the first one I would say is standardization in data management or service quality definition. So, for example, in the past we have 5 centers that offers post-transplant MTAC, but then after revision we had to consider 3 instead of 5 because our country has 3 transplant centers. Yeah, and to standardize the definition of pre-MTAC and post-MTAC, and to differentiate between MTAC and extended counseling. So those are one of the reasons. Second is changes in patient preferences for drug and information delivery. This is very, very apparent during the current pandemic season. However, this factor has already started in the last few years when our value-added service were being introduced. Patients were more preferred to have their medication posted to them at home or come and collect their medications by appointment without waiting at the clinic. And we are also having this difficulties to maintain our well-trained staff, where there are very high staff turnover before we can even afford to train another batch of staff. Okay, and when we talk about this, the challenges in a bigger view are almost 7. And these challenges are being seen by not only nephrology MTAC, but all MTAC services. We do need, one, the challenge is in the IT integration, and this challenge is even more prominent now when people are going for online consultation. Yeah, we need an internet backbone, we need hardware, We need space. We need a conducive environment to have this IT being worked out. Number two, we are moving forward in a very advanced service and environment, but we are still having the traditional staffing model. Yeah, we are not fluid when it comes to staffing model, a bit rigid when it comes to that. Third is about incentive of motivation, training roadmap as the official blueprint at the national level. We need to have more progressive outcome measures, effective succession planning, and also continuous quality assurance and R&D program. Right. Now, having said that, I'm coming to my the last part of my presentation, which is to look into the sustainability plan. What are we going to do, at least in the next 5 to 10 years as a start, to ensure that MTAC program is still valid in the current healthcare system, and the pharmacist role can be upscaled to a higher level than what we are having now. We have done very good compared to the last 10, 20 years, but we cannot stop here. So how are we going to maintain and sustain this? So looking into that, the Nephrology Pharmacy Service, we did a SWOT analysis in 2018, which was 1 year before the COVID-19 cracked out. So this SWOT analysis make us sure that we have a good strength and also quite a lot of weaknesses, equal opportunity, but also some threats that we may not be able to counteract. In terms of the strength, we have many experienced team members, good supporting collaborators, and they have very good demand, for our service. But we may need to brush up in our research coordination, accreditation for the training, and also the opportunity for subspecialization for the experienced renal pharmacists. And where do we want to hang this? The best thing that we can do as this SWOT analysis was not done at the policy making level, it is done at the grassroots. So we look into the FIP development goals. So in this FIP goals, it is a key resource for transforming the pharmacy profession in any level that you are at, And for each of these goals, they have 21 here. Each of these goals has components of elements for practice, science, and workforce. And for each element, they also provide a mechanism on how we can engage to it. So when we look into the 21 goals, for renal pharmacy, at least we can look into or go deeper in 5. The first one was the competency development. At the practice side, there is a need to develop frameworks that can measure competency. In leadership, it will not happen by its own. The person in charge, the policy makers, or the seniors there must have a strategy and program to develop this leadership with opportunity for professional autonomy, advancing integrated services, where there must be an interprofessional integration with other, not only with non-pharmacists, but also pharmacists of other expertise, Impact and outcome, there must be evidence on how the existence of this service can contribute in quality of life, efficiency in healthcare, and also sustainability. Digital health, no explanation is required for this because it is very, very important at the moment. And having all those key words and key needs, we transform it into a client chart, a 5-year plan. So the diagram that you're looking here is a very brief summary of tremendous work that has been put into the 3-feet plan of the nephrology pharmacy services for the next 5 years. The first initiative in the next 5 years is to strengthen the CKD retardation strategies in collaboration with Diabetes MTAC. It means that now we have to start collaborating with pharmacists of other subspecialties, and we will tag along existing services rather than creating new ones. Number 2 is to strengthen the effectiveness of pharmacy training, because we have to look into evidence of competency and also accreditation. Number 3 is to have a standard clinical outcome as the national KPI of the service, yeah? And to make the Renault Pharmacy Handbook, which is the most referred materials in the country, to go electronically and to make it well used as an ongoing continuous pharmacy education. And number 5 is to increase the number of quality renal pharmacy research through collaborations and funding whenever possible. The main person or the main agency that will have to carry out this plan or this initiative are the Renal Pharmacy Working Committee, and the stakeholders that we have to buy in is the main committee of the clinical pharmacy in Malaysia, the Malaysian Pharmaceutical Society, and also the State Pharmacy Service. The required resources and also the key milestones for each of these initiatives already has a fixed or a flexible 3-peak plan for the next 5 years. I am currently not in the position to explain further about this 3-peak plan because they may have changes amid the COVID pandemic. But if you are interested to know how these are being tabled out for the next 5 years, you can email me, and then I will get you connected to the current chairman of the Malaysian Renal Pharmacy Working Group. Yeah. And with this, I would like to acknowledge the Clinical Pharmacy Committee, the Nephrology Pharmacy Working Group, and the Renal Pharmacy Chapter of the Society for the archive of materials and information. Thank you very much.
Thank you, Dr. Nur Kasihan.